Bacteremia is a term used to describe the presence of bacteria in the blood intermittently and in relatively few numbers. Once the replication of bacterial cells increases and the presence of bacteria in the blood is significant, bacteremia can become sepsis, a serious, potentially life-threatening complication. Although most bacteremias resolve themselves through normal immune response, infection may worsen in immunocompromised individuals. As a result, the presence of bacteria in the blood is a result that should always be considered significant. A large variety of organisms are known to cause bloodstream infections. These include coagulase-negative Staphylococcus, Staph aureus, Enterococcus species, and Viridian streptococci. Staph epidermidis is a common cause of wound infections, and it's one of the most common pathogens known to cause bacteremia associated with indwelling medical devices. In hospital settings, these isolates can be challenging to treat due to the emergence of multi-drug resistance Staph epidermidis phenotypes.
We were given case 6, where a patient who was hospitalized and recovering from a heart attack had developed a fever and inflammation around the insertion site of a urinary catheter. Specimens collected from the patient include a wound swab from the site of catheter insertion, urine samples from the catheter, and blood cultures.
A wound swab around the catheter insertion site was plated on blood and McConkey agar. Due to the low oxygen levels in necrotic tissues, anaerobes are commonly present at the site of wound infections. Therefore, the sample was cultured on 2 blood plates, one aerobic and the other anaerobic. After 24 hours of incubation, the overall growth on the aerobic plate was better than the anaerobic plate. Based on the colony appearance, 2 types of organisms were isolated from the wound swab. One organism grew as white, dry, non-hemolytic colonies with rough edges on HbA. It was catalase positive, and the gram stain revealed short gram-positive bacilli uniformly stained with Chinese ladder arrangement. The colony morphology and the gram stain of the organism were consistent with diphtherioids. This was confirmed by streaking the organism on potassium telluride blood agar. API colony was set up for organism according to manufacturer's instructions. After 24 hours of incubation, light green colonies with green center grew on the telluride agar, which is consistent with diphtherioids. Based on the biochemical reactions of the API strip, the organism was identified to be diphtherioids. The other organism grew as creamy non-hemolytic colonies with smooth edges on HbA, and overall aerobic growth was better than the anaerobic growth. Colonies on the McConkey agar were lactose fermenting and grew poorer compared to the blood agar. The organism was identified to be gram-positive cocci with perfect spheres and was tested catalase positive and coagulase negative. Based on the initial test, the organism was identified to be coagulase negative staph. The organism was streaked on DNase agar, Novobison sensitivity, and API staph was set up for confirmed ID. After 24 hours of incubation, the organism was identified to be DNase negative, as the media around the colony remained green, indicating that the organism does not contain the DNase enzyme required to hydrolyze the DNA in the media. The Novobison disc had a zone of inhibition, indicating organism sensitivity to the antibiotic. With these results, along with biochemical reactions on the API strip, the organism was identified to be Staphylococcus epidermidis.
The urine cultures presented some interesting yet confounding findings. The microscopy of the urine samples presented red blood cell and white blood cell counts of approximately 10 to 100 by 10 to the 6 cells per litre, which is within normal ranges. However, numerous squamous epithelial cells were found within the sample, with a value of 10 to 100 by 10 to the 6 per litre. This is congruent with epithelial contamination. Additionally, the cells found were squamous, which is again consistent with contamination and not a UTI. The sample was plated on horse blood agar in aerobic and anaerobic conditions, in addition to McConkey agar. 3 distinct organism communities were present on the blood plates. Organism 1 grew as a large black beta hemolytic colony on both the aerobic and anaerobic HbA plates, and lactose fermenting on McConkey. The organism was also catalase positive and oxidase negative. A confirmatory API 20E was undertaken, and the results indicated E. coli. Organism 2 grew as large white gamma hemolytic colonies on both the HbA plates, as well as lactose fermenting on McConkey. The organism was catalase positive and oxidase negative. A confirmatory API 20E was done, and the results indicated Proteus mirabilis. Organism 3 grew as a large, grey, rough, beta hemolytic colony on both HbA plates, yet was non-lactose fermenting on McConkey agar. The organism was both catalase and oxidase positive. A confirmatory API-20 NE was done, and the results indicated the organism was Pseudomonas aeruginosa.
2 out of the 4 blood culture bottles flagged positive for the presence of bacteria. Samples from the blood cultures bottle were plated on 2 horse blood agar plates. One was incubated under aerobic condition, while the other one was incubated under anaerobic condition to cover the possibility of anaerobic blood pathogens. Blood samples were also plated on McConkey agar. There was a creamy growth on HbA02 plate, and overall growth on blood agar incubated under aerobic condition was better than the agar incubated under anaerobic condition. The colonies were lactose fermenting on MAC plates. However, the overall growth on McConkey was weaker compared to blood agar. The gram stain of the organism was gram-positive cocci in clusters. Biochemical tests revealed the organism to be catalase positive and coagulase negative. At this point, the organism was believed to be staph epididymis, and final identification tests were set up, which included DNA tests, novel biopsy, and API. The organism was identified to be DNA negative, as media around the colony stayed green and novel biopsy sensitive. Consistent with staph epididymis, the API confirmed Staphylococcus epididymis.
Antibiotic susceptibility testing of the isolates occurred to give the medical practitioner a range of possible treatment options. Susceptibility testing also occurred on the isolates recovered from the urine sample and wound swab using similar methodologies, although in the following I'll be focusing on the blood isolate. Following the standardized UCAS method, a lawn was set up on a Mueller-Hinton agar plate using an inoculant with 0.5 McFarlane turbidity, prepared from the recovered Staph epidermidis. This was also done with a control strain in order to check antibiotics were functional. On the now inoculated plate, antibiotic discs were placed. The various types of antibiotics used and their concentrations can be seen in the table presented. The plates were then incubated for 35 degrees for 16 to 20 hours. The zone diameter around each antibiotic disc was measured to determine if the isolate was considered sensitive, intermediate, or resistant. In the isolate of Staph epidermidis recovered from the blood, sensitivity was found to erythromycin, gentamicin, vancomycin, and ciprofloxacin. Resistance to penicillin and cefoxitin was detected. Sensitivities of the control strain were also checked. Methicillin resistance among staphylococci is a well-known issue affecting antibiotic treatment. Disc diffusion tests using oxacillin were found to be unreliable in the detection of methicillin-resistant coagulase-negative staphylococci. Instead, cefoxitin is used to detect methicillin resistance through a surrogate marker. Cefoxitin works by inducing the MEK resistance gene if it is present in the organism. As our isolate tested resistance to cefoxitin, we can conclude that the organism is methicillin resistant.
There are many factors which influence how significant the isolate recovered from the wound site may be. Firstly, it is possible that the organism recovered from the wound swab were contaminants of the swab, as both diphtherioids and as Staph epidermis are normal skin flora, and during collection of specimen, these contaminant organisms could have been deposited on the swab. As skin commensals, these organisms are usually non-pathogenic. However, it is also possible that the isolates recovered as normal skin flora, which have contaminated the catheter wound site, have caused infection. Staph epidermidis has previously been linked to infections of wounds left by medical devices. Diphtherioids and Staph epidermis are nosocomial pathogens and are known to cause infections in immunocompromised patients during prolonged hospital stays. However, we are not able to comment on the significance of this influence as we are unaware of the immune status of the patient.
The 3 organisms isolated from the urine were Pseudomonas aeruginosa, Proteus mirabilis, and E. coli. Although all of these organisms individually have been known to cause catheter-associated UTIs, generally urinary tract infections tend to be monomicrobial, and the presence of mixed growth is usually a good indicator of contamination. In addition to this, the epithelial cell count was above the acceptable range, again indicating contamination of the specimen. Red and white blood cell counts were also within the normal ranges, supporting the hypothesis of a UTI not being present. As all 3 organisms are commensal flora of the human gastrointestinal tract, it is highly likely that fecal contamination has deposited the organisms in the urine during specimen collection, where they were allowed to grow and replicate to significant levels, giving the significant count of 10 to the 8 colony-forming units per litre. As a result, we believe that it is highly unlikely that the patient has a UTI, and that the results obtained from the urine sample are not to be considered as clinically significant.
Although Staph epidermidis is commonly isolated from blood cultured bottles, it is true infection in only around 6.3% of patients Staph epididymis is known to be one of the most popular contaminant of blood cultures due to its presence in abnormal skin flora, which can contaminate blood during collection. In the present case, isolation of Staph epididymis in 2 out of 4 cultures bottles is highly consistent with genuine infection rather than a contamination. If it had only been present in single bottle, it is likely that the presence could be attributed to contamination. Detection in only 2 out of 4 culture could be due to a relatively low level of bacteria present, which is commonly in bacteremia. Staph epididymis is a common pathogen known to cause bacteremia in patients with indwelling medical device. As Staph epididymis was recovered from both the blood and wound site, it is likely the bacteria from the wound site had entered the bloodstream.
There are a number of improvements which could be made, both to this particular scenario and to other similar situations in the future. Typing methods could be used to determine the strains of Staph epidermidis recovered from the blood and wound sites. This information will be useful in concluding if it was the same strain that was present in the 2 sites, and hence if the presence of Staph epidermidis in the blood was directly related to its presence in the wound. By looking at the similarities and sensitivity patterns, a relationship is quite possible, but typing would be needed to confirm this. In addition to this, typing could also be used to establish whether the bacteria originated from the patient's endogenous skin flora or if it came from some other outside source. It might be considered beneficial to recollect a new urine sample from the patient, taking appropriate measures to ensure that the risk of recontaminating the sample is reduced. This would be done to definitively exclude the possibility of a UTI being present. The urine sample should be taken midstream, with the collection area adequately cleansed and healthcare workers using gloves to minimize the possibility of depositing contaminant organisms. In the identification and susceptibility testing methods previously mentioned, predominantly manual techniques were used, aside from the automated systems used for blood. However, using automated identification susceptibility testing would allow for results to be obtained more quickly and by using more standardized methods, reducing the risk of human error affecting the results obtained.
In conclusion, Staph epidermidis was isolated from the patient's blood, indicating bacteremia. Since Staph epidermidis was isolated from both the wound swab and the blood culture, it is highly likely that Staph epidermidis isolated from the wound infection at the catheter insertion site entered the bloodstream and caused bloodstream infection. Although molecular typing methods would be needed to confirm this, treatment then commenced using suitable antibiotics, which were suggested to the practitioner. As the patient was likely started on antibiotics as soon as the cultures flagged positive, but before organism identification, therapy was amended to suit the specific infection.